How's it going, guys? Difficult question, pathology, step one, internal medicine, surgery, 2CK. We have a 44-year-old woman who has a 12-hour history of deep vein thrombosis. And this was diagnosed via duplex ultrasound of the thigh, okay, swollen, painful left thigh. And she's got obviously edema of the face, the infraorbital region, the lower back, that's presacral, and of her ankles, okay, moderate bilateral pedal edema. So what's most likely to be seen in this patient? If you've been following my content, you've seen that I've made a clip or two talking about this before, but let's just run through. Choice A, decreased activity of factor VIII, which would mean hemophilia A. Wrong fucking answer, okay? Outrageous answer choice. I mean, you can easily eliminate it. It's X-linked recessive, okay? And you would have bleeding diathesis, increased propensity for bleeding, not clotting. So on multiple levels, it's wrong. They'll tell you that you've got a school-age kid who has hemarthrosis bleeding into a knee. They can tell you that a maternal uncle died from mild head trauma. You're going to have an isolated increase in PTT with hemophilia. Wrong fucking answer. Choice B, DIC, wrong fucking answer. Okay, so this is going to be when you have a runaway cascade / activation of the clotting factors, okay, and also of your platelets. So consumption of clotting factors and platelets where bleeding time PT, PTT all go up. Miscellaneous multifarious etiologies such as sepsis, trauma. You can have more specific etiologies such as amniotic fluid embolism, treatment of APL, where you release rods into the circulation, cause DIC. They want you to know that D-dimer is going to be increased. It's fibrin degradation products. Fibrinogen is decreased. Plasmin activity is increased. And you're going to see schistocytes in a blood smear. It's a long discussion. If you're confused, go to my hematology PDF. Choice B, wrong fucking answer. Choice C, failure to cleave von Willebrand factor multimers, wrong fucking answer. So this refers to TTP, thrombotic thrombocytopenic purpura. It's a very buzzy answer choice that some of you have seen before. So it's a long discussion as far as deficiency of or antibodies against ADAM-TS13. It's a matrix metallopronase that normally breaks down von Willebrand factor multimers. And TTP is going to have a pentad. It's going to have it's a microangiopathic hemolytic anemia. So you're going to have thrombocytopenia, schistocytosis. The combination of those two is called MAHA, microangiopathic hemolytic anemia, plus renal issues, plus fever, plus neurologic signs. Long discussion, same as with choice B. If you're very confused right now about TTP, go to my hematology PDF. I talk about it. Wrong fucking answer. Choice D, membranous glomerulonephropathy, correct answer. So this is a nephrotic syndrome. Okay, miscellaneous etiologies could be tumors such as breast, pancreatic. It can be autoimmune diseases, SLE, IBD that cause it. It can be primary antibodies against phospholipase A2 receptor. It can be drugs, dapsone, gold salts, sulfonamides. Okay, so it's a nephrotic syndrome, and we don't necessarily know the etiology, nor do we care, but she's clearly got edema here. And more of a 2CK level point is that if you have presacral lower back edema, that's very rare, right? Some of you watching this clip, you've never even heard of that before. Well, that's going to be nephrotic syndrome until proven otherwise. Okay, it shows up on a 2CK question for nephrotic syndrome. So you need to, and you say, but what's going on? What's the connection to the DVT? Okay, and I've made prior clips on this, as I mentioned before, is that nephrotic syndrome is an important cause of antithrombin 3 deficiency. So antithrombin 3 is a protein, you lose it in the urine, and you can become hypercoagulable. So you get DVT, superficial thrombophlebitis, you get renal vein thrombosis, okay, and you can get varicocele. That can lead to varicocele in males, all right, very important for USMLE. So this vignette, I said it's difficult, but it's actually pretty buzzy over time as you become more accustomed, okay, to doing questions. You'll just see, oh, sounds like someone who's got edema, with nephrotic syndrome and a DVT. Oh, that's easy. That's just antithrombin 3 deficiency. Not complicated. Let's just whip through the final one. Reduced ABIs, wrong fucking answer. TCK surgery, IM point, which is going to be for arterial disease, okay? So this is clearly a venous problem. So if we have diminished peripheral pulses, intermittent claudication, history of coronary artery bypass grafting. If we're talking about peripheral vascular disease, we're going to do ABIs first. It's a test comparing blood pressure in the arm and to the ankle. Okay, and so if the ratio is low, under 0.9, that's peripheral vascular disease. And then you do an exercise stress test. If it's not listed, you're going to choose exercise/walking program. Don't jump on cilostazol. ABIs, wrong fucking answer. You know the deal. To make more content, like, subscribe to my channel. Appreciate your time. That's it.